Welcome, everyone. I'd like you to welcome to our webinar today titled Toilet Training, Tips, Tricks, and Evidence-Based Implementation, brought to you by the University of Iowa Division of Child and Community Health, Child Health Specialty Clinics, and the Regional Autism Assistance Program. My name's Rochelle Swanson-Holm, and I will be moderating today's session. The session will be recorded, and the link to that recording will be provided in a follow-up email. You are free to type your questions in the question box throughout the presentation, and those will be answered during the last few minutes of our time together. Continuing education credits will be available for those attending the live session. Directives for obtaining those are in the handout section, and they will also be emailed to you later this week. Again, welcome, and I'm excited to introduce our presenters today. Samantha Cermak is the ABA Clinical Manager at ChildServe and oversees the clinical development of ChildServe's ABA program. Samantha has been a board-certified behavior analyst, licensed behavior analyst in the state of Iowa for 11 years. She has practiced in homes, clinical and school settings, primarily focusing on supporting children with autism diagnoses and their families. She has clinical interests in early interventions for toddlers and young children with autism and family training. Dr. Suzanne Richards obtained her PhD in counseling psychology from the University of Illinois, Urbana-Champaign in 2007. She is a child and adolescent psychologist specializing in the assessment of autism and intervention with individuals with complex medical, psychological, social, and behavioral conditions related to autism. Dr. Richards has been involved in clinical education and research on multiple topics, including school violence, bullying behavior, learning, healthy sexual behavior, and social skills. She has extensive clinical experience providing mental health therapy services and assessment in a wide range of settings. She has served many children, adolescents, and their families with behavioral disorders, in addition to major mental illness and autism spectrum disorders. Dr. Richards joined ChildServe in 2016 as a psychologist, and since this time she has become an integral part of the interdisciplinary autism diagnostic clinic and is involved with various autism interventions, including treatment groups, diagnostic assessments, and consultations on complex children, programming, and training. Dr. Margaret Barsetti graduated from Creighton University in 2018 with her doctorate in occupational therapy. She joined ChildServe in 2018 and since has worked with many children and families with a variety of diagnoses and goal areas. Maggie has been a part of ChildServe's interdisciplinary autism diagnostic clinic and feeding clinic. She works collaboratively with other professionals to evaluate and create treatment plans for children with complex medical needs. Maggie is involved in autism programming and developmental and outpatient group therapy services. She provides direct care to children in ChildServe's Autism Day program and ABA classrooms. So again, we've got a great panel of speakers, and I'm going to turn it directly over to them so they can begin their presentation.
Thank you. We're just delighted to be here today. We don't have any disclosures to disclose, but we're really happy to get to present some information today to you. It goes without saying that when parents have concerns about toileting, the first place they reach out to really are, those primary care providers. And so we're going to be presenting how to evaluate, how to know if the child's ready, some common strategies of what to do, and what are those best practices. the context of toileting is that it's really a big deal. It's a big deal to parents for lots of reasons. There's a lot of emotional ties to parenting a child who's not toileting on an expected timetable. Parents feel like they're a failure. They worry that their child is somehow not going to ever get to be independent. And so they start to think about, oh no, I can't send my child to school now. And so one of the things that's really helpful for parents is to allay some of those initial concerns, like you're not a failure, your child can go to school. Quite frankly, even if your child is not ready for school, school has to be ready for your child. And so, kind of allaying some of those concerns can take some of the pressure off and actually, make toileting a lot easier, because if mom and dad aren't stressed, that's going to make things a lot better. They get pressure from relatives, and that's never helpful. One of the other things, that becomes, a weighty issue for a lot of parents is the fact that diapers are expensive. But with a diagnosis, and a lot of times with developmental disabilities, there's a diagnosis. Insurance can start to pay for diapers at age 3. And so, offering that support is a great support. And again, those primary care providers can offer that prescription so that that's one less stress for parents. So there's a lot of things that kind of go into that initial conversation that can just allay some of that pressure and make the process a lot easier. When we think about the process, it's really best addressed, again, taking some of the pressure off, thinking about it in that hierarchical manner of, are there some medical concerns that we need to tease out? Are there some simple, taking, again, that pressure off, that emotional pressure off? Are there just some simple behavioral suggestions we can go through? Are there some sensory concerns that we need to address? Or are there some really complex behavioral solutions that we need to go through? And that's really what we're going to talk about today. So that kind of hierarchy of looking through all of those problem-solving pieces. It's also important to note that there are some cultural differences in toilet training. Different cultures look at things differently. Globally, the further you are from the equator, the longer it's going to take you to potty train, which is fascinating. The warmer the climate, the sooner you're going to toilet train. So within the US, this has changed over time. We're taking longer and longer to toilet train. The ability to have greater diapers, that don't that are more absorbent, I guess, right? Take away that urgency to change, because kids don't necessarily feel wet, and so they're not getting that instant notice that they need to get their diaper changed. Another interesting fact within the US is that non-white children are toileting or beginning toilet training about 6 months earlier than white children. So there are those kind of cultural expectations that to be sensitive to.
So the first question that we often get is, when is it the right time to start? And there are many, many factors that can contribute to that conversation that we're going to kind of go through in the next few slides. There's a variety of skills across a variety of developmental domains that we really do need to consider when we think about when is it the right time to start for my child. None of these are a reason to potentially not start toileting, but it is kind of a basis for a conversation to determine if we are ready. So from a developmental perspective, we might want to evaluate, is that child able to transition to the bathroom, sit on the toilet, staying dry for up to those 2 hours at a time, some of those motor skills with pulling pants up and down, following some simple instructions, and is there a way for that child to initiate or communicate that they do need to go to the bathroom. And then from a physical perspective, a child must have voluntary control over their pelvic muscles. And this is something that your child grows into over time. We might not have control over this aspect, and it can be variable over time. Hey, Maggie, I think your mic is.
Yes, thank you. There are also two parts with behavioral readiness and parenting readiness. A huge part of toileting is the parent's readiness to kind of dive right in and work through a lot of different factors that might impact toileting along the way. Some key factors with overall behavioral readiness that we want kids and their families to be on the lookout for is just children being able to imitate different behaviors outside of toileting. This will help them learn all the toileting, including hand washing and working on donning and doffing clothing. We also want to make sure that children are having a good ability to say no and showing some other signs of independence in their daily lives, which will help to be a good sign that the child is also motivated to start working on toileting. It's always really helpful when the child is interested in the toilet and they're wanting to work on working on toileting. This just really helps make sure that they're having a really positive experience when they're working to learn this skill. Parenting readiness is a huge factor. It really takes a lot of people involved with toileting to really make sure that children kind of get a really great foundation. Their own readiness should be kind of one of the main factors that parents are looking for as well. A lot of times, if children are coming to see a specialist to work on toileting and parents aren't ready to kind of dive right in, that's a big conversation that we have with families right up front. Knowing that toileting is a lot of different paths to get to the end result, and it can be messy and it takes a lot of people involved in a lot of steps. There are a lot of specialists that have really great different ways that we can work on toileting that we'll get to a little bit further on that presentation, but making sure that parents are involved, making sure that parents know that typically punishment or criticism of themselves or their child really is not proven to be a really great strategy to use, so making sure that everyone is on the same page to start off.
So one tool that you can use is really just a toileting skills checklist, which we put together across kind of those different areas to evaluate, is a child ready? And it's really just a reference point that you can use in those conversations. So again, not all of these need to be checked. Not all of those developmental kind of milestones need to be met in order to start toileting, but it really does help set the conversation up to determine what are some factors that we may want to consider or may want to think about before jumping into toilet training. So this is a checklist. The items that have the asterisk by them are really some of those more critical components, I would say, to toileting. So those would be tolerating sitting on the toilet for 2 minutes. Oftentimes when we start having conversations with families about toilet training, maybe the child isn't yet tolerating sitting on that toilet. And we can then think about what are ways that we can help support that child to feel more comfortable sitting on the toilet, and how do we work our way up to kind of that child feeling comfortable with the 2-minute mark. And Maggie's going to go through some great recommendations and strategies in a few slides. And sometimes that means we're going to start with 1 second sitting on the toilet, and we're going to work our way up. So there may be specific points of this checklist that we really have to target first before we are going to consider saying that child is ready for toilet training. Another one of those would be the parent readiness. When we do more intensive toilet training, we do go from underwear or go from diaper or pull-up to underwear, and we don't look back unless it's nighttime. So we want to make sure that the parents are ready to stop wearing those pull-ups or diapers completely, knowing there will be some hard moments, there will be some messes, and we will get through them, but to kind of stop wearing those diapers. And then the next question is the child tolerating underwear? Oftentimes that might be an area too that we want to more intensively focus on before we start toilet training. So helping the child feel comfortable wearing underwear. And again, we might really start at 1 minute of tolerance of the underwear and then work our way up before we want to start toileting. The next piece is medical conditions that may impact toileting. Constipation is a big one, among other factors that could impact toileting, that we want to make sure that we have thought of, that we've had a conversation of, that we have coordinated with medical providers to provide input on that and have a plan in our toilet training plan. And then the other piece is finding a dedicated time for a family to really focus on toilet training. So, and that's a conversation point too that we often have with families to make sure it's the right time. And then after we have that, the next piece is to start tracking, that we ask a family to track how often their child is eliminating. So this is just a sample data sheet that a family can mark every 30 minutes, dry or wet. And that really just helps make a more a better plan for each child that is going through toilet training. A plan where a child eliminates once a day because they hold it all day at school and get home and eliminate looks very different than a plan for a child that is wet every 30 minutes. So we just want to make sure we have a really good understanding of all of this kind of critical skills. We have a conversation around each of those before we want to dive on into potty training.
Once we have a good idea of kind of what a child's schedule is, what parents' ability to dedicate time to work on toilet training, occupational therapists really do a deep dive into those foundational skills that are necessary for a child to be successful with toileting. So I'll be kind of talking about a couple key areas, starting off with motor coordination. When we think of toileting, there are a lot of motor planning and fine motor coordination skills that go along with that. Grasping, manipulation skills, strength, and their overall bilateral coordination skills, so them being able to use hands together and knowing where their body is in space, are really things that they have to have a good grasp of in order to be successful with parts of toileting. If we think of toileting as a whole, some just examples of times when we're using fine motor skills are pants fasteners, snaps, belts, being able to pull down pants and underwear easily, so they're not really stressed about doing that. Wiping is another huge part of toileting that we need to work on. And then just overall being able to manage their coordination in the bathroom. So when children have deficits with fine motor skills in general, these things are going to be challenging for them. So really making sure that the occupational therapist is working on strengthening these skills so they're able to be more independent with those motor coordination pieces of toileting. And making sure that parents know that it might take extra time for their child to work on these skills in the bathroom. Sometimes we'll get kids that are very independent and they want to do all these things by themselves, and that's great, but if we're in a rush to use the bathroom and it takes them longer to manage the fasteners, just making sure that parents know that maybe given a little bit of extra time with that part of toileting is going to help their child in the long run. And really making sure that we are breaking down all of toileting for parents. So when we're working on this, we know that we are going to have to look at motor skills, their overall sensory processing skills, their interoception skills, and make sure that they have really good abilities to do those things independently, and that will all help them be more independent with toileting as well. Another large part of toileting is a child's interoception skills. So interoception is defined as our ability to process information with our internal conditions. So that might be needing to go to the bathroom, that we're hungry, that we're tired, and different things like that. A lot of times if children don't have great interoception skills, they are going to have a hard time reading their body's signals that they need to go to the bathroom. It's going to be those kids that all of a sudden they are playing with a toy and they get up and they've had an accident or they run to the bathroom. Those kids that have really urgent needs and the parents are saying, well, why didn't you tell me earlier? Sometimes those kids really don't know that they need to go to the bathroom until it's urgent and it's happening right then. Overall difficulty with interoception skills can be seen in a lot of different areas of a child's life, And occupational therapists can really help build those interoception skills to make sure that children are ready and able to learn to read their body signals more independently. A lot of times we are working through these skills through different sensory processing and sensory regulation strategies, as well as making sure that we are informed with kind of when their body's natural timeline is to use the bathroom, and helping those kids kind of break down those signals, what's happening with their body. Another large part of toileting is overall reflex integration. I will say this is one that some kids have retained primitive reflexes and it does not impact toileting. Some kids do have retained primitive reflexes and it is a huge factor in their ability to be more independent with toileting. This is something that occupational therapists can assess to see if they do have retained primitive reflexes, and then also really have a conversation with family on if those reflexes are impacting their functioning. Just overall retained reflexes can play a role in overall developmental delays, including toileting. So really focusing on, there's two reflexes that are paired with toileting a lot called spinal pres and spinal galant. And sometimes if children have those or are positive for those reflexes, that can have a really big impact in their ability to have control over their bowel and bladder, which makes toileting hard. This usually ends up being something that we look at for older children that are having a really hard time staying dry at night. Maybe at night they're having a harder time waking up to know that their body needs to go to the bathroom, and most of the time those kids end up having retained spinal pres and spinal galant reflexes. This is something that families have to be on board with, doing daily exercises to help integrate those reflexes for kids so they're more independent with toileting. It's something that takes a lot of time for families to do, and they have to be very consistent with the home programming that's provided. It's also something that parents have to help their child with. There's a lot of passive reflexes that parents are providing to their child, so making sure that they are feeling comfortable and confident in doing those reflex integration exercises too. And one of the last key factors that we'll talk about that play a role in toileting are sensory processing concerns. A lot of kids who have a diagnosis have different sensory processing needs. They are kids that might be moving a lot, or they might be kids that have a really hard time with their overall body control. And working on sensory processing as a whole can really help them be more independent with toileting. There are lots of different senses involved in toileting, including touch, sight, hearing, smell, interoception, and vestibular input. So just some examples of how sensory processing can impact toileting are just kids that have a hard time with different textures, touch, have a really hard time with transitioning to sitting on the toilet seat. They're used to going in a diaper or a pull-up. They're wearing them every day. They're not having to pull them on and off. And then toilet seats, we've been told, are cold, and kids don't really like that big transition. So really making sure that they're working on positive experiences in the bathroom and really breaking down different parts of sensory processing that can play an impact in toileting. Another big thing that we hear a lot from families is just all the sounds that are happening in a bathroom, especially public restrooms. The automatic flush, other people washing their hands, drying machines. There's just a lot of sounds going on, and there are lots of times really sudden, and kids can't see that that's happening, so they've kind of learned to be scared of those sounds. So different things that we have tried are headphones when they're going into public restrooms, trying to modify your own bathroom so it's a little bit more of a quieter experience, and just making sure that parents are supportive in those environments, and knowing that that might be different for their child if they're independent at home but are struggling more at school or in public restrooms. Another big thing that we see with kids is just their overall body awareness with their proprioception skills. So if we kind of jump from a 3-year-old who has been using a pull-up and putting them on a toilet that an adult uses, those toilets are really big. There's usually not support for their feet, and they usually have to kind of use their strength to stay up on the toilet. And that's a lot of times where you hear about kids feeling scared that they're going to fall in the toilet. A lot of times kids if they have an experience that was really negative when they're kind of working on toileting at the beginning, kind of have an all or none mentality. All toilets I'm going to fall into, or all toilets are scary, or all bathrooms are loud. So really making sure that we're modifying their environment from their beginning to make sure that it supports their sensory needs. A lot of times with home bathrooms, we have a lot of adaptive seating options. So here are just a couple of examples of different ways that parents can use different types of toilet seats. It really depends on the kid, and it really depends on the home. These are not something that families have to purchase. If the child is working with an occupational therapist, we are great at being creative with figuring out what families have at home and modifying them to make it work for their home and their child. But the important things are just making sure that the child feels supported when they're working on toileting, so it's not as scary for them. One thing that most of the time for outpatient occupational therapy services, we usually only see a child and a family one time a week. So working on toileting really takes a bunch of collaboration and making sure that families are following through with home programs at home. Sometimes just meeting once a week is not enough of an intensive model for children to really make a lot of progress with toileting. So they might work with some other professionals on that more intensive toileting model.
So I'm going to give an overview of what a more intensive kind of toileting procedure or model might look like. And when we think intensive, we think about intensive because it is multiple days in a row. So typically we're implementing this 2 to 7 days in a row, and it is implementing a protocol the entire waking day of that child. So when we say intensive, we mean it from the perspective that we are actively working on toilet training most of the day that child is awake. So because of that level of intensity and need for a whole team or parents or specialists to be working with that child, we really want to make sure that we are evaluating those key toilet training readiness skills that I've reviewed. Because if we have missed one of those, going into a 2 to 7 day intensive toileting will be more difficult. If we haven't yet thought about the child tolerating underwear or tolerating multiple transitions to the toilet, then that day is going to feel pretty tough for that child, because we're working those skills are hard on top of learning toileting, and it will be harder on the caregiver or the person that's implementing, because we're targeting kind of two things at once. So again, just to reiterate, that pre-training, that checklist of some of those critical skills is a critical component of starting more intensive toilet training. Once we have those readiness skills identified and we have made a plan, the first thing that we will do is communicate the expectations for the family. So level of involvement, how do we run the protocol? Typically when we do this with families, we're practicing together and then feeding ourselves out over time. And then the other piece that we want to make sure we have identified is a communication or initiation system for that child. Every child communicates differently, and so we just want to really think about their skill set and their strength in communication and what might work for that child. So an example might be putting up visuals throughout the home of a bathroom, so the child can utilize a visual quickly and make it super easy for that child to initiate. And there are multiple examples of how we might adapt that communication system for the child. And then we would like to next determine that sit schedule and fading plan. That sit schedule is based on the data that the parents have given us from that wet, how often their child is wet or dry. So again, a child that's dry all day and really only eliminates one time a day, this plan will look very different from the child that is frequently eliminating. So this is just one example of what your kind of sit schedule might look like. So the first column looks at the schedule. The second column is how are we going to, what reinforcers might we consider using in in the procedure. And then the last column discusses, how do we know when we're ready to be done with the schedule? How has this child mastered it? And are they moving to the next phase? So the example on the first row there is maybe the child starts with 10 minutes on the toilet and then has 10 minutes off of the toilet. What our reinforcement for that child during those times is, on the toilet, we're going to be singing songs, we're going to do ABCs, we're going to do all the things they love to make the experience as enjoyable as possible. And after the child eliminates, that's when maybe their favorite game is on the iPad, we're going to have them access iPad. And then we know that child is ready to move on when they've had 2 successes on the toilet, or 2 times that they've eliminated, and 0 accidents for 1 hour. Then we know a child is ready to move on to our next schedule, which might be 5 minutes on the toilet, 20 minutes off. We're going to keep our reinforcers in place. We're going to keep our mastery level, and then we can move to the next phase. Once we get to that phase where the child is spending 60 or more minutes off the toilet and is staying dry for up to that half day, that's when we really want to start waiting for that child to initiate to us. So again, it might be that child is walking to the bathroom, could be an initiation, or it's that child communicating to an adult, I need to go to the bathroom. And so now we're really focused on that child initiating, eliminating, and that's how they might access their most preferred item. And then once they meet that criteria, now we are going to be able to fade out the extra reinforcement, and we're just going to just rely on praise and having that toileting be now part of that child's routine and day. So this fading plan, again, is it's very different for every child that we work with. And it might take 1 to 2 days, or it may take up to that 5 to 6 day mark to completely fade out, to wait for that child to initiate. A couple of other components of the plan is when that child is not on the toilet, they either are in underwear or are and have kind of nothing on. And during those times is when we are actively engaged with that child and are able to immediately redirect if that child starts to have an accident. That immediately redirect is very neutral, very supportive. Oh, remember, we go pee in the toilet, and we walk together, we sing our songs in the toilet, and we practice and remind the child, oh, this is where we go, this is where we go to the bathroom. Every dry pants check is sometimes part of our process, which can include like initially every 5 or 10 minutes, having that child be actively aware, are their underwear wet or dry, just to keep them actively kind of engaged in the process and as a reminder. Most children who can follow some of those instructions or can follow like a first then type of schedule, or like kind of our more rule governed, like we sometimes we talk about ABA, we typically implement the dry pants check with. Children who are not yet kind of following those instructions, or we typically don't include that as part of the process. It just really depends on that kiddo's and communication use. The next portion of the intensive toileting protocol is our liquids. We do try to have that child drink more liquids, or just make sure they're getting enough throughout their day. So there are opportunities for us to reinforce and to practice eliminating it in the toilet. That has been something that has come up before, where a child doesn't like to drink or drinks all at once. So when that happens, we might modify our sit schedule a little, but it's something for us to consider. And then we're going to fade that schedule out, as we talked about in the previous slide. And then reinforcement is, extra reinforcement is kind of always part of our intensive toileting protocol. So the biggest pieces with reinforcement that we talk with families with is it needs the delivery of the big thing that we're going to give after you eliminate it has to be immediate. So it's probably one of the most important portions of reinforcement is once that child is eliminating, they're aware they're eliminating, we want to make sure we're delivering that really fun, preferred item that we've established. Distinct really means that it stands out to that child. This is different. Something is happening. This is not an everyday item that I get all day. The next piece is contingent, which is probably one of the hardest pieces as we kind of think through what are effective reinforcers. So when something is contingent, it really does mean I'm only giving this to my child after they eliminate on the toilet. They're not able to access this item any other time of the day. So sometimes things like maybe the TV might be really hard because there's other people in the environment that want to watch TV. So it might not be the best choice for some families. Or that's just one example. There's different items that might be like that might not be the best choice. So we really want to think about something that's contingent. And then there's kind of this continuum, which is the visual below, where ideally we would stick in that like praise or the natural reinforcer land, the things that would naturally happen when the child goes to the bathroom. People will probably say, great, awesome, you stayed dry. But most of the time, if we are at the intensive kind of toileting protocol stage, we are kind of in that orange zone of we really want to think about the highest preferred option to utilize, and then we will fade that out and get back to praise. But just thinking of it as on a continuum is helpful.
Sometimes kids don't need quite the intensive behavioral protocol. Sometimes they don't have a sensory concern, but there might be some mental health concern that's developed, or some bad habits that have developed. And good parents will have some concerns about, why is my child still having some accidents, not consistently, but episodically, and they may seek some guidance. A lot of kids who are in the elementary age group will end up seeing a urologist to rule out some different concerns like, UTIs or problems with voiding. And it may just be that they have a fear of missing out. Or maybe, they were getting extra rewards, and so they weren't quite eliminating fully because they really liked some of the rewards. Sometimes kids develop some bad habits that way. Perhaps they just have a lot of constipation, and so there's some problems with toileting that way. And then sometimes kids have some, emotional concerns that they've developed, and they don't like to go into the bathroom. Sometimes kids regress after they've developed a new skill, and so then they backtrack in their toileting. So parents get very concerned about that. But if we ruled out some of those medical concerns, and now we're looking at, fear of missing out, or it's more of an emotional concern, we can look at other options that are more, simple behavioral, or, simple emotional sorts of concerns that are more, geared towards mental health. If it's not a significant developmental disorder, if it's more maybe an ADHD concern, if it's a fear of missing out, there are, a timed avoiding system. You can get the little wristband that buzzes about every half an hour for kids to remind them and make them a little bit more aware of the need to try and void. And that can be, very sufficient for some kids. And that's part of the bell and pad technique for the daytime. For the evening, that looks a little different. Again, lots of parents struggle with that, with a variety of kids, just due to neurological immaturity. And again, that can vary from, pretty typical kids, who maybe have a little bit of ADHD, or just are very typical, all the way to our kids who have significant developmental disorders, who are still having nighttime enuresis all the way, into their preteens or later. And it can get in the way of their social abilities if you want to send them to, sleepaway camp, if they're more normative, all the way to it just gets expensive and frustrating to do laundry all the time, So, there are some other solutions, that mental health or psychology would offer. Lots of things don't work. Punishment just doesn't work. Sometimes parents try, well, I'm going to have them do their own laundry. That'll help them learn not to wet the bed. It does teach the skill of laundry. I will give you that. But it doesn't seem very effective in reducing wetting at night. So a lot of frustrated parents come in with that. You can wake them up in the middle of the night and have them go to the bathroom. And that seems to be intermittently effective that night, but it doesn't really teach anything either. Restricting fluids might help that night, but it doesn't change their neurology. So a lot of parents try things. Drug therapy is an option, especially if it's, you're waiting out, neurological immaturity, especially if you want to send them to sleepaway camp. That's totally, reasonable. But if you just like primitive reflex integration can be helpful, so can a bedwetting alarm. And the technology has really changed over the years, and it's much more reasonable. You can refer parents to primitive reflexes, and obviously that's some work for families. It can take some time and effort. So is the bedwetting alarm. They can buy the underwear that as soon as a little drop of liquid hits the underwear, the alarm goes off, and it initially just wakes up the parents, who then wake up the child and then take them to the bathroom. But after a couple of weeks, it will wake up the child and they will eliminate in the bathroom. And, usually in about 6 weeks, you have a lot more success, and they're getting dry at night. Sometimes you have to repeat the protocol, but it's nice to see that, there's some success for most kids. And what you're really promoting is some neurological growth, much like what you would see with primitive reflexes. But it takes time and buy-in from the parents. Another issue of independence for kids is that issue of wiping. A lot of parents complain that their children are just lousy at wiping, especially boys. And nobody likes to do laundry like that. So it can be even worse for our kids who have some sensory concerns. They don't like to wipe. So one of the suggestions for helping kids get more comfortable with wiping is to shape that behavior. My suggestion is simple, but to shape that behavior with using a regular paper towel. I like Bounty because it's very similar to Charmin in its feel. And then use a separate garbage can filled with wonderful garbage bags that your Hy-Vee or Fairway has given you, and take the paper towel roll, cut it in half because it looks a lot like your paper towel, or sorry, your toilet paper, and it comes off in a small amount. Get it wet and wipe, and you can help them initially, but then they can do it themselves, and you throw that into the garbage with the grocery bag, and it goes out to the curb or wherever that garbage is. Eventually, less water, more dry. Eventually, you can start using regular toilet paper because they've gotten used to it. And I think for most kids, that's really the issue, is that when they were younger, those wet wipes were comfortable. Toilet paper is not. Wouldn't you rather use a wet wipe? But the wet wipes aren't necessarily great for your sewer system. So it's really just kind of helping them kind of graduate from what was a little bit more comfy to that, and to be okay with the fact that they're wiping, you know, a BM from their bottom and into the toilet. So there's a lot that they're having to get used to. There's a lot that you have to get used to when you move from the diaper to the toilet. And with younger children, you're asking them to do quite a lot. And for parents, you're asking them to do quite a lot. Often the first time doesn't quite click. And when it doesn't first succeed, parents feel a lot of shame, and they kind of go on hiatus from that experience. When it's time to try again, parents and children both are kind of, traumatized by that experience, and they're very anxious. So when they go and try it again, there's a bit of self-compassion that parents need to embrace. And then they really need to pull out the big guns, the big rewards, the really patient and wonderful approach for their kids. So just like, Samantha was talking about, what are the only things you can have when you sit on the toilet? And what's the different approach that you can have this time when you sit on the toilet? Can we move the toilet into the living room instead of the bathroom this time, and then gradually bring it back in, so it's a little kinder and gentler approach than last time, or we were just going to wait it out, because that didn't work the first time. It has to be a different way for kids.
Yes, and sometimes as kids get older, for a variety of reasons, maybe parents decided to put a pause on working on toilet training, and now the kid is older and they're wanting to work on toilet training again, or the child had some sort of an accident and now they're needing their parents' help with toileting, and they're trying to become more independent. As children get older, they start to kind of understand and notice some different social things between them and their other peers. So they can have some more anxieties towards working on toileting because it's not necessarily something that their friends are doing at school. So a huge part of working on toileting with older children is that child must be motivated to work on whatever their level of independence is with toileting. If the child isn't motivated, it usually results in some sort of a power struggle between the child and the family and professionals that are working alongside the child, and oftentimes that doesn't lead to the best results. We really need to also make sure that we are listening to whatever the concerns or anxieties the child has with toileting. Sometimes they might seem silly or might not be something that we necessarily would think of, but to the child, these are real anxieties, and we need to be able to make recommendations and modify different things to help them feel more comfortable and safe with toileting. A lot of times there are just some underlying factors of general anxiety that now are popping up with toileting, and really making sure that the child has supports from mental health professionals, and making sure that families are feeling supported too. As parents get older and as their child gets older, they don't necessarily want to always be helping with toileting every single day. So making sure that parents are feeling supported too. With occupational therapy, I will share that the level of independence with toileting can look different with every child and every family. So making sure that the families feel comfortable with sharing their concerns, and making sure that they're feeling comfortable with implementing whatever strategies can help their child as they get older. Our next slide includes kind of the selective bibliography of where we got our resources today for the presentation. And now we will open up to any questions you guys have.
Oh, how wonderful. Thank you, Samantha, Maggie, and Suzanne. That was a wonderful presentation, and we really learned a lot about some great strategies for toilet training for our children that we serve and their families. Before we take the questions, I want everybody to take a couple minutes and be sure to get some questions in the question box. We have a couple right now, but if you have any others, be sure to enter those now. But I also, right before that, I want to be sure to remind everybody that there are some handouts in the handout section, 2 handouts, the PowerPoint from today's presentation and also the directions to obtain your CMEs or CEs. You will be able to self-claim your CMEs and CEs through the University of Iowa College of Medicine portal. And if you have any issues, you can always email me, and I'll be happy to try to help you attain those. So we do have a couple questions. Let's see here. Okay, so the first one is about medication that is prescribed, particularly DD-AVP, which I quickly looked up. And maybe you ladies already know about that, but it's desmopressin, which some providers prescribe to control the amount of urine in the kidneys. So can you make any comments about that? This individual is seeing more and more of that prescribed.
Having never gone to med school, that wouldn't be something that I would speak to. I see it prescribed too, and there are other medications out there as well. But the comment I would make is that it is a way of kind of suppressing, right? And so it's a strategy that a lot of primary care prescribers would use to kind of help when needed, to help kids who have that neurological immaturity.
Well, thank you. Another question in the box is, what are some methods for building the prerequisite motor skills for toileting?
I'll say with just kind of our overall fine motor skills that are necessary for toileting, a lot of times kids are working on those skills through play. So building with blocks, coloring, self-feeding, and kind of just working on those fine motor skills in different areas of their development. And then a lot of times how occupational therapists end up working on toileting, who are also working on fine motor skills, is the child is already active in our service and parents bring up concerns with toileting and we kind of go from there. But for specific fine motor things, usually those kids are working on developing those skills around the same time that they're working on toileting too.
Okay, well, thank you. Another question, at what age would you refer to occupational therapy?
That's a really great question. I think that it is dependent on the child and the family and what their concern with toileting is. I will say that it's difficult when we get a child that's referred for concerns with toileting and parents have not tried anything at home. Usually it's when they've tried these things aren't, their natural progression of toileting is not working and they're needing some extra supports. I would say the most common age that we end up seeing kids that have concerns with toileting in the early ages is between 3 and 5, and then sometimes we get kids on the older end, I would say 10 to 12, if now the child's motivated or parents want to try again. But really that parents trying things first is really necessary for them to be successful in occupational therapy.
Okay, great. And then I had one more question. Do you have any suggested visual schedules for children that we could use?
Yes.
Yes, yes. I think that definitely adding a visual component to any toileting plan can be super helpful for a child who is very used to kind of following a structure and following a schedule and routine. Even thinking about preschool classrooms, typically bathroom time is a scheduled activity that's part of the routine and day. And then thinking about visuals from an initiation perspective, sometimes we want to consider too, when is the right time to fade out if we are using visual? When is the right time to fade out so that child is beginning to initiate independently? So if we're in the middle of target and the child needs to go to the bathroom, they are able to also have that skill set. As far as specific visual schedule, I guess templates or visuals that we've used, oftentimes, honestly, it's a piece of paper with Velcro strip and putting the visuals that are on it, kind of a low-tech option. I don't know if the others have any more ideas or typical visual schedules that you've used.
I would say ours are usually similar to what you've talked about, Sam, and then you're really able to specialize that schedule to that specific child. Maybe they just need, I go to the bathroom, I sit down, and I flush. Some kids need that whole breakdown, like I go to the bathroom, I pull down my pants, I sit on the toilet, I get off the toilet. So it really is dependent on kind of how much support that child needs too. But we usually use that lower tech option.
Well, and whether or not you need like a self-soothing statement in there too, right? Like, and I will be okay, or, you know, so.
Yeah, I think that is all the questions that we have to in our question box. I would just encourage the audience, if you have any other questions, you're sure welcome to email me, and I'll be happy to contact Sam, Maggie, and Suzanne for any answers and share those with you. So again, I really want to thank our speakers today, and I want to thank our audience for joining us. It was a great learning topic, and I hope all of you can join us in 2023 for our next set of webinar series. So, and if you have any special requests for topics, I'd be happy to entertain those. So thank you again, everyone.
Thank you.
Thank you.
Bye.